Hello everyone, myself Dr. Parth Goswami, and after discussion of thalassemia hemoglobinopathy, now we will continue in a hematology with a sickle cell hemoglobinopathy. So today we will discuss the sickle cell anemia from the hematology chapter. This is very important topic in a hematology. So first of all, what is the hemoglobinopathy? So as we have discussed in our previous lecture as well, it is a hereditary condition that involves the abnormality in the hemoglobin structure. So hemoglobin structural abnormality is known as a hemoglobinopathy. Now there are two type of problem can be hemoglobin structure. Either you have a decreased production of alpha or beta globin chain, that is known as a quantitative defect. The example is thalassemia, or you can have a qualitative defect in which the abnormal hemoglobin is produced because of genetic mutation. The mutation means change in DNA structure. So if the abnormal hemoglobin is produced, if a qualitative defect is there, then the example is sickle cell disease. We know that our hemoglobin is made up of heme plus globin, and in globin we have a two alpha and two beta chain. So if the defect is in this globin chain, then sickle cell disease can occur. So first of all, what is the main genetic etiology behind the development of sickle cell anemia? So it's basically because of missense mutation. Here the glutamic acid will be replaced by valine in the sixth position of beta globin chain in a HBS. So in a hemoglobin in a beta chain, at the sixth position, glutamic acid is replaced by valine. That is a basic genetic defect. And because of that, the solubility of hemoglobin is altered, and so HBS is formed, which will form a tectoid, and it can obstruct the blood supply to the affected organ. In a heterozygous state, usually it doesn't cause infarction. Heterozygous means only one chain is affected, and that patient is known by the name sickle cell trait, like that of thalassemia trait. So this patient doesn't manifest much severe. But if the sickle cell disease is homozygous, means both the chains are affected, then sickle cell disease will develop, which is very severe, which will lead to very severe clinical manifestation and infarction as well. So this is the master flow chart that explaining the molecular basis for the pathophysiology of sickle cell disease. So this is the pathophysiology of sickle cell disease, why there is a symptom in a sickle cell anemia. So in a sickle cell disease, basically whenever the oxygen level is low, it could be because of dehydration or infection like precipitating factors. So because of that, because of low oxygen, the solubility of hemoglobin HbS is altered. So it will undergo aggregation and polymerization. And we can easily, imagine that because of polymerization and aggregation, they will form a needle-like tectoids. They will form a fiber, thick needle-like tectoids that will accumulate within the RBC, and it will grow within the red blood cell. And because of that, RBC become elongated because the tectoids are growing within the RBC. So the RBC become elongated and it will assume a shape of sickle. That's why crescent moon. That's why it is known as a sickle cell disease. Here the RBC shape will be sickle shape, crescent moon shape, right? So, this particular sickled RBC will predispose to a slowing of blood flow, and it can lead to vascular occlusion. Repeated such sickling and de-sickling attack. Whenever oxygen level is low, sickling will occur. When the oxygen level is normal, the de-sickling will occur. Means RBC acquired normal shape. But this repeated process, ultimately lead to irreversible sickle shape RBC, which will manifest clinically as an infarction because they lead to vascular occlusion. They will obstruct the blood supply. So see, because of that, if the renal papilla is affected, then renal papillary necrosis will occur. If the bones are affected, then osteomyelitis can develop. In an infarction of the hands and finger, painful swelling can occur at the tips of the finger or hand or foot, right? Congestive cardiac failure can develop, and such sickle RBC, removed by the spleen by the process of hemolysis. So patient can have a hemolytic anemia. So it will manifest as a jaundice because of the hemolysis. The protoporphyrin, biliverdin, and bilirubin will ultimately form from the heme. So patient will have a jaundice because of hemolysis. And, sometime if the severity is more than retinopathy, and stroke can also develop. So that's all because of vaso-occlusive crisis. All the clinical manifestation is because of vaso-occlusive crisis. And such vaso-occlusion usually occur after 6 months of age if the patient is having sickle cell disease, because after 6 months, HbF level is decreased, which is protective. HbF will provide the oxygen. So after reduction of HbS, after the 6 month, the vaso-occlusive crisis will occur. And as we have discussed, precipitating agent for the low oxygen level is dehydration and infection. So because of sickled RBC, vaso-occlusion, there could be necrosis in the bone, lung, brain, renal papilla, spleen, and liver. So because of low blood supply, coagulative necrosis will occur, which is known by the name infarction. So infarction is nothing but a ischemic coagulative necrosis. And because of this infarction, patient will have a tremendous pain, and it will last for a few minutes to several days. The patient will complain of pain according to the affected organ. See, hand and foot syndrome means dactylitis. If there is an inflammation of the small bone of hand and feet in the first 2 years of life, so it will manifest as a painful swelling in the digits, and patient will have a very much pain of the digit. One important clinical manifestation, as we have discussed, that is the avascular necrosis of femur bone. So patient can have a pain in that area. Usually the head of the femur is affected, and this necrosis is purely aseptic, right? It is not because of infection. So that is known as a aseptic necrosis, also known as a osteonecrosis. There is a pain, tenderness, and disability because of that. All right. Sometimes this sickled RBC can obstruct the pulmonary vasculature, so it can lead to pulmonary infarction. And because of that, lung function could be impaired, and the patient will manifest as a cough, dyspnea, chest pain, or hemoptysis because of acute chest syndrome. If the renal papilla is affected, then there will be necrosis of the renal papilla. Now, why renal papillas are particularly affected by this disease? So that's because of relative hypoxia and hyperosmolarity in the renal medulla. So it will create a suitable environment for the sickling of RBC in a vasa recta. So because of that, sickled RBC will develop. So it will lead to ultimately destruction of loop of Henle because of necrosis, and it will manifest as a renal papillary necrosis, and ultimately it will put a patient at a risk of renal failure. And because of renal failure, the toxic metabolic waste product will accumulate, and it can lead to encephalopathy and finally death. Hematuria can also be seen because of this papillary necrosis. So sickle cell disease is one of the important cause for the renal papillary necrosis. If the secondary infection by parvovirus B19 occurs, then patient will have a aplastic crisis in which the patient will manifest as a pancytopenia, means the hemoglobin, WBC, and platelet, all three lineages will be decreased because of aplastic crisis. And the patient will have a profound anemia because of that. All right. Spleen is congested because they are removing the sickled RBC. So it will enlarge earlier in the childhood. But because of repeated sickling, desickling, repeated infarction of the spleen, because of obstruction of the circulation of the spleen, there will be infarction. So because of repeated infarction, ultimately fibrosis and autosplenectomy will occur. Because of repeated infarction, the spleen will be removed automatically within our body after few years. So that is known as a autosplenectomy. Blood circulation in the spleen is slow because of vaso-occlusion by sickled RBC. So the main clinical manifestation, now you can understand that it's because of vaso-occlusion, and the main pathophysiology behind the vaso-occlusion is formation of tactoids because the solubility of HbS is altered under low oxygen level. And that solubility is altered because of genetic mutation where the glutamic acid replaced by valine at the sixth position. Now, which are the laboratory tests for identification of sickle cell anemia? So first you can do the screening test, that is a peripheral blood smear finding, right? And CBC that can be done initially. So in a CBC, complete blood count, hemoglobin level and PEG cell volume will be decreased. Reticulocyte count is increased because the patient will have a hemolysis within the circulation, because this abnormal hemoglobin will be removed, so patient will have a hemolysis, and because of hemolysis there is a erythroid hyperplasia, so the reticulocyte count is increased in a blood, and it is reflected in a peripheral smear as a polychromatic RBC. See, this is the polychromatic RBC, this is the nothing but a retic. In a PBS peripheral blood smear, it is reflected as a polychromasia. There is a variation in the size and shape of nucleus. This RBC is small, this is large. So that is known as a anisopoikilocytosis. Variation in the size and shape of nucleus. You can see size and shape of RBC. Here you can see that this RBC is sickle shape. This is normal. So poikilocytosis is also observed, right? So sickle cell is one of the example of poikilocytes. Abnormal shape of RBC. Hypochromic RBC also observed. This is a hypochromia. Sickled RBC is seen in peripheral smear. See, this is a sickled RBC. This is classically sickled RBC. This is all, right? This is also sickled RBC. This is sickled RBC, sickled RBC. So that's because of sickle cell anemia. And obviously, in a bone marrow, you have a erythroid hyperplasia because the body will need a more RBC, right? Because these abnormal RBCs will be removed from our body because they are abnormal. So we need a more RBC. So erythroid hyperplasia is observed in bone marrow. All right. Which biochemical test can be done for the sickle cell anemia? So these biochemical findings are non-specific. They are more or less suggest towards the hemolytic anemia, but it can't say 100% that it's a sickle cell anemia. Because of hemolysis, bilirubin will be increased, and we know very well that unconjugated bilirubin will be increased. That we have discussed in thalassemia lecture as well. So because of that, pigmented gallstone will develop. Because of hemolysis, the iron storage will be increased. The ferritin will be increased, iron will be increased, and transferrin saturation is increased, like that of thalassemia. If you want to study it in detail, then that why storage is increased, then you can see my lecture on hemolytic anemia, which is very good. So I suggest that first you see the lecture of hemolytic anemia, then thalassemia, and then see the sickle cell anemia lecture. Urine urobilinogen will be increased, right? The bilirubin level is increased, particularly urobilinogen in the urine is increased because of hemolysis. All right. And haptoglobin will be reduced. Now, what is sickle solubility test, which is also one of the screening tests? So, in this particular test, the anticoagulated blood is mixed with a reagent solution that contain the phosphate buffer, saponin, and sodium dithionate. So, this saponin and sodium dithionate will lyse the RBC. Now, if the patient is having normal adult hemoglobin, alpha 2, beta 2, then the solution is clear because RBCs are lysed, the solution is clear. Turbidity will not form because they doesn't have HbS. But if the patient is sickle cell anemia, then because of HbS, solubility is altered. So they will form a tactoid which will refract the light because the tactoid will not allow the light to pass. So it will refract the light and solution become turbid. So this is a simple, very simple sickle solubility test for distinguishing between the patient having sickle cell disease or not. It can't differentiate between sickle cell trait and disease, right? Heterozygous, homozygous cannot be distinguished. It can only say that whether sickle cell disease in your body, sickle RBC is present in your body or not. So see, this is the positive test where the turbid solution is turbid and the light is refracted. Black line is not visible. So this is called as a positive sickle solubility test. All right. Now, after doing the CBC peripheral blood smear, in a peripheral blood smear, we can see a target cell as well. That I forget to mention. See, this is the target cell. So it can also be seen, right? So after doing the peripheral blood smear, CBC, biochemical test, sickle solubility test, how will you confirm the sickle cell disease? So the confirmation is by a electrophoresis or HPLC. The gold standard test is high performance liquid chromatography. Electrophoresis also can be done. Now, if we talk about the electrophoresis in detail, then it can be done in a two pH. One is alkaline pH, that is the cellulose acetate method, and at the acidic pH, that is known as a citrate agar method. So, in this cellulose acetate method, the pH is alkaline. This is the cellulose strip, which will put in a chamber and surrounding which we have a trace buffer. Now the two electrodes are placed, that is a cathode and anode, and the electric current is applied. So the each hemoglobin is having the different amino acid constituent, right? This each hemoglobin having different amino acids. That's why they have given the different name. Because in adult hemoglobin we have alpha 2 beta 2. In a fetal hemoglobin there is alpha 2 gamma 2. In the S we have a HbS. We have a mutated beta globin chain. In a A2 we have a alpha 2 delta 2. So because of different amino acid constituent, they have given the different name. And so because of different amino acid structure within it, they will migrate at a different rate in this electric current media, right? Whenever we apply a current on a strip, they will migrate at a different rate. See, here we have applied the hemoglobin solution. Now from cathode to anode, the migration rate is different. The most the farthest migration, the, the adult hemoglobin will migrate the most fast, right? While HbF migration is somewhat slow. Still slower rate of migration is observed in SD and G. And finally, least migration rate observed in A to C, A, E and O hemoglobin. Now see here you can see that you can't distinguish HbS, D and G, right? Because they migrate at the same rate here. So how will you distinguish? See, this is a sickle cell, but we can't say it is a HbS, D or G. So for that differentiation, you need to do a citrate agar electrophoresis, in which these three will migrate at a different position. So this is a simple electrophoresis test. But this is not a gold standard because you can't do the quantification, right? You can't easily distinguish between the disease and trait. So the most frequent method that is used is HPLC. See here, this is the sickle cell anemia where HbS is seen. But the gold standard method is high performance liquid chromatography. Now, what is the principle of this procedure? How it is done? So, in this, the blood sample is introduced in a matrix column. See, this is the matrix column, which is stationary phase, and this is the mobile phase, right? Along with solvent, the blood solution is injected. So that's why it is known as a mobile phase. Now, it is injected in a HPLC column, which is stationary phase. So, whenever it is injected, the HB mixture get adsorbed on the matrix, and after adsorption they will elutate at a different time. They will take a time for a elution because their amino acid constitution is different, their structure is different, so their charge is different, right? So they will elutate at a different time, and absorption of such eluted hemoglobin is measured and interpreted accordingly. So it will measured and interpreted in a software. All right, so that is the basic principle of HPLC. All right. Here you can see that there is a peak at the HbS. See, this is the sickle cell anemia case because you have a peak in a HbS. HbF is also increased. So in a sickle cell anemia, you have increased in both HbF and HbS. The main peak is in a HbS. All right. So HPLC is a gold standard method for the confirmation of thalassemia and sickle cell disease like hemoglobinopathy. See, this is the HbS, but here HbD peak is also seen. So it is associated with HbD, HbS, HbD combination. Here the peak is HbS, so it is a sickle cell anemia case, sickle cell disease. Now let's discuss about the three other hemoglobinopathy as well in short. So what is HbC disease? So HbC is a sixth position of beta chain is affected where the glutamine is replaced by lysine. It could be trait or disease, means homozygous or heterozygous, and the target cell is seen in peripheral blood smear. In electrophoresis, it will migrate very less. And, it is a least hemoglobin to get migrate. The migration rate is very slow, right? So this is HBS. However, the best is HPLC method for its detection. HBD Punjab, East Indian population is mainly affected, and in this hemoglobinopathy, there is a change at the 121 number of amino acid at beta globin chain position, where the glutamic acid replaced by glutamine. So glutamate replaced by glutamine, and patient will have a mild hemolysis, right? It will migrate along with HBS, right? HBD Punjab. So that's why you need to do the citrate agar electrophoresis, or you can need to investigate with HPLC. All right. Now, what is HBE disease? So it is mainly observed in Southeast Asian population, and in which at the 26th amino acid position of beta globin chain is affected, where the glutamine is replaced by lysine. It could be a trait or disease, and patient will have a microcytic hypochromic anemia. All right, and it will migrate at this position along with HbA2, C and O. So obviously it can't be distinguished by cellulose acetate electrophoresis, so we need to do a citrate agar electrophoresis where it will migrate with other hemoglobin, not with C and O, right? But the gold standard is HPLC again. So for all hemoglobinopathy, gold standard investigation is high performance liquid chromatography. So that's all about the sickle cell hemoglobinopathy. Now let's discuss some of the MCQ. Which of the following statement regarding pathophysiology of sickle cell disease is true? Sickle cell hemoglobin HbS polymerize in deoxygenate state and lead to RBC sickling and vascular occlusion. So it is a right sentence. Because of vascular occlusion, there is an infarction, right? Alright. Sickle cell disease is caused by mutation in alpha globin chain, which is totally wrong. The mutation is in beta globin chain. Alright. Second MCQ. A 10-year-old boy with a known history of sickle cell disease. See, the sickle cell disease is present. Patient complaining chest pain, dyspnea, and fever. Chest X-ray shows pulmonary infiltrate. Was it most likely diagnosis? So here we are dealing with infarction in a lung because of obstruction of pulmonary vasculature. So it is a case of acute chest syndrome. These are my references for the today's lecture. I hope your fundamentals regarding the sickle cell disease is clear. Again, I am summarizing in 1 minute. See, the main pathophysiology is that under the low oxygen level, HBS will undergo aggregation, they will form a dactoid, and it will give the RBC a sickle shape. And this sickled RBC can lead to vascular occlusion by stasis of blood flow. And because of occlusion, patient can have an infarction in the variety of organs like that of bone, lung, renal papilla, spleen, and liver. And that's why the patient will have a pain in the affected area. So that's the clinical presentation. In a PS, we can see a target cell, N-isopoikilocytosis, sickled RBC, right, and polychromatic RBC. In a biochemistry, we can have an increased ferritin, transferrin, and iron level, and obviously because of hemolysis, bilirubin will be increased. In all hemolytic anemia, bilirubin is increased. Sickle solubility test can be performed as a screening test, but the gold standard is HPLC. Electrophoresis also can be done in which the hemoglobins, different hemoglobins will migrate at a different rate because of their different charge by different amino acid constituent, right? So here you can see a HBS, it will migrate at this position. But the gold standard is HPLC, in which you can quantify the hemoglobinopathy defect as well. Means the exact percentage of abnormal hemoglobin also can be calculated. Here the HB mixture will get introduced in a matrix column, which is stationary phase, which don't move, right? We inject the sample into it, and so different hemoglobin adsorb onto matrix, and they were eluted at a different time because of their different amino acid constituents. So they will elutate at a different time, which can be measured and interpreted accordingly. So that is a very useful test for sickle cell disease. Here you can see a spike in a HBS. So this peak is because of sickle cell disease. So that's all about the sickle cell disease hemoglobinopathy. I hope you have enjoyed this particular lecture. Thank you very much, and I will be right back with some of the more interesting lectures. Thank you very much. Till then, take care and bye bye. Take care.